Welcome to the very exciting last session of IVHEM 2020, Achieving Health Equity Through Hepatitis Elimination. My name is Michael Ninberg. I am the Executive Director of the Hepatitis Education Project based in Seattle, and I am going to introduce our first speaker, John Ward, who has a long history working in viral hepatitis, as many of you know. Recently at Centers for Disease Control in Atlanta, and now at the newly established Coalition for Global Hepatitis Elimination. And without further ado, John is going to give us an introduction to this very exciting session.
Good day, and welcome to Achieving Health Equity. We're going over a few concepts about health equity and how they're applied to hepatitis elimination. In 2016, when the World Health Organization issued the recommendations calling for the elimination of hepatitis B and hepatitis C, we joined a very select part of public health that has been directed toward disease elimination and eradication. And you realize when you look at the history of disease elimination and eradication, that the guiding principle is health equity. The concept that you're going to apply a variety of public health measures and interventions to a large population, preferably a country and then progressively the world, so that everyone in that country benefits from that intervention. Now you're seeking to do that through direct interventions applicable to that disease and then general health system strengthening that comes from that. And then with these targets that are helping you create a sense of urgency, bring important partners to the table, and have accountability as you measure your progress toward these time-limited goals. But with all of that process is to achieve health equity. For us in hepatitis elimination, our goals are a 90% reduction in incidence and 65% reduction in mortality by 2030 for hepatitis B and hepatitis C. So those are our global targets. But we recognize that hepatitis is not uniformly distributed around the world. We have about 257 million people living with hepatitis B, the highest prevalence in countries of Asia and in Africa, and hepatitis C, about 71 million people. And then you have, again, differences geographically. So that's one health equity that has to be recognized, geographic differences. Then as we begin to think about the interventions that can be applied to achieve our elimination goals, we again have to think, how can we apply them to achieve health equity? The cornerstone of hepatitis B elimination is hepatitis B vaccination of infants beginning at birth, preferably within 24 hours after delivery. When that vaccine is applied, we see large reductions in prevalence among vaccinated cohorts, such as has been achieved in China, as shown in this slide, with some work still to be done in countries such as in sub-Saharan Africa. So in the case of this health disparity, there's a decision made that every infant should receive hepatitis B vaccine, even though that the infants at highest risk are those born to infected mothers. But because of the safety and effectiveness of that intervention, at the time of birth, and then completing that series later in infancy, it's recognized that you can achieve much more effective prevention than through some other targeted means. So hepatitis B vaccination is actually an excellent example of a general or broad application of intervention to eliminate a health disparity and achieve health equity. Another issue related to health equity for hepatitis B is the migration of persons who were infected with hepatitis B in early life in countries that had not yet implemented hepatitis B vaccine, and then moving to a country that had a lower hepatitis B. An excellent example of achieving health equity within a country for hepatitis B vaccine comes from China, where it was recognized that hepatitis B birth dose delivery was a particular challenge for children born at home, and they could not be reached in a timely way to deliver that vaccine when it could be most effective. So a decision was made to increase the facilities, particularly in rural areas, so that children could be born in that facility rather than being born at home. That move probably had improvements in multiple aspects of maternal and child health, but it did create the environment where timely birth dose of hepatitis B vaccine could be delivered, resulting in a large increase in birth dose coverage for hepatitis B vaccine in China, helping that country achieve the regional goal of less than 1% prevalence among children vaccinated for hepatitis B. So again, a broad adoption of an intervention to remove a health disparity and achieve health equity. Another example of a health disparity for hepatitis B is the movement of persons infected with hepatitis B in early life from countries where hepatitis B vaccine was not yet put in place to other countries where hepatitis B prevalence is lower. I provide an example of countries in the European Union where they recognize that a sizable proportion of persons living with chronic hepatitis B were migrants from highly endemic countries. So it provides the information to direct hepatitis testing and linkage to care for those migrant populations. Of course, that needs to be done in a social, culturally appropriate way that can be well received by those migrant populations and be done in a way that's not stigmatizing so that they are reluctant to accept those services when they're offered. But it's important to have that information to begin with so that you can act on that information to benefit those populations. There are also differences in the prevalence for hepatitis C. Indeed, about 20 countries account for over 3/4 of HCV-related deaths. So again, at the global level, it's important to prioritize resources and technical assistance to those countries that have the highest prevalence of hepatitis C or the largest number of people living with HCV infection. Transmission in healthcare settings through unsafe injections still accounts for a sizable proportion of all infections with HCV. So it's very important to improve infection control for healthcare delivery. Now, when you look at it globally, there's been about over a 90% reduction in HCV transmission because of improvements in injection safety related to healthcare. So those countries are seeing declines in HCV infection as a result. Some countries are still challenged. I'm providing an example of Pakistan, where infection control still needs to be improved in healthcare settings. So that disparity still persists, but through sharing lessons learned from those countries that have been successful in this area can assist Pakistan improve this aspect of HCV prevention. You can also begin to direct services to large segments of the population. In the case of the United States, it was recognized that persons born between 1945 and 1965 had an increased prevalence of hepatitis C because of exposures prior to viral discovery in 1989. So we recommended that all of these persons be tested for hepatitis C in 2012. And then over time, the number of persons born in these years increased, particularly so in just the most recent years, contributing to a decline in hepatitis C mortality as those persons that were diagnosed were being treated, cured, and having a much less risk of liver-related complications from their cured HCV infection. So again, this is an example of how you can target a large segment of the population to reduce their disparity of risk for HCV-related mortality. You can also target a facility. It's well known that the incarcerated populations have an increased risk of HCV infection. That's true in almost every country around the world. They're often marginalized because of their incarcerated state. They're really at the disposal of the government of whether that testing and treatment services are delivered to them. So this population definitely is a high priority based on prevalence, and because they're marginalized and unable to receive the services on their own action. Then lastly, you can target populations based on a risk for transmission. And of course, for HCV, the greatest risk for transmission is among people who inject drugs. As a result, the incidence is quite high in that population. The prevalence is quite high in that population. They need prevention services to provide safe injections and access to drug treatment programs, as well as the HCV testing and treatment. So this is a major area. Again, these populations can be marginalized, can be stigmatized, so they need extra attention so that they do benefit from an HCV elimination program in the country at large. So health equity is front and center of everything that should be going on around hepatitis elimination. And that has to carry through to the very end of the program when you're beginning to document progress and document achievement of goals. We are currently working with the World Health Organization as they begin to identify, we're beginning to work with the World Health Organization as they begin to develop guidance regarding how to document achievement of these global goals for hepatitis B and hepatitis C. And it's important to look at how health equity is handled in other disease elimination efforts. Now, the Western Pacific region has already, for many years, has had a hepatitis B control program with time-limited goals, with a verification process in place. And in that region, there's an advisory committee that documents the achievement of reductions in prevalence, but with particular attention being paid to the populations where there may be the greatest likelihood of hepatitis B vaccine not being effectively delivered and an ongoing risk for transmission underway. So recognizing those subpopulations at highest risk. Similarly, for HIV and syphilis elimination, there's a recognition to specifically address lowest performing administrative units where the prevention efforts may be the most fragile and the most limited, so that you're looking at the weakest part of the system rather than a focus on the strongest. And then lastly, just again, looking at the approach for malaria elimination, how again, they're calling out those populations at highest risk for transmission of malaria, and perhaps those that again have the poorest access to preventive services. So in conclusion, health equity is the guiding principle for disease elimination. The achievement of health equity can be addressed in a variety of different ways through the delivery of broadly of an intervention throughout a population, or by targeting subpopulations or particular settings or populations at risk. At the end of the day, we want to achieve our elimination goals in a way that every person in that population benefits. Thank you.
Thank you, John, for really beautifully setting the stage for this discussion around equity and elimination. I think for a lot of us who are in the field working to get people tested and treated and cured in the case of hepatitis C, or on treatment in the case of hepatitis B, or vaccinated for hepatitis A and B, the idea of leaving no one behind is really front and center for what we do, and trying to get to the most marginalized, the most vulnerable first, because we know that's going to be the difficult part when we get to the final stretch on the road to elimination. I am thrilled that we have such an esteemed panel today, and we're going to kick it off with Homi Razavi, who I'm sure is familiar to most, if not all of you. Homi is the founder and managing director of the Center for Disease Analysis, or CDA, and since 2008, Homi's team of epidemiologists has done really groundbreaking work on the epidemiology of viral hepatitis around the globe. CDA also works with countries to forecast future disease burden and develop national hepatitis strategies. And to start, Homi is going to tell us about a very exciting program that he and his team have been working on in Uzbekistan for the past couple of years. Homi?
Well, thank you so much. It's such an honor to be on this panel. And I want to thank the organizers for the invitation to be here. As you mentioned, we have really focused on quantifying the epidemiology and the burden in the countries, and really helping countries develop their national strategies. But about 2 years ago, we realized that we really had to get involved and roll up our sleeves to get involved in elimination programs. And we formed the Global Procurement Fund. The Global Procurement Fund is a mechanism where we do pool procurement for hepatitis. And we started the program in Uzbekistan to screen, test, and treat hepatitis B and hepatitis C. And the program is really focused on just the capital city, Tashkent, right now. And I'm going to tell you a little bit about it. So the idea is simple. You essentially have countries like Egypt, like Pakistan, like Spain, who are willing to provide free diagnostics and treatments for the population and eliminate. But there are many countries who cannot afford to do that. And the question is, how do you actually finance those? And so our concept was that if you bring the prices down low enough, provide free screening, free lab tests, in fact, some portion of the population will be able to afford to pay for it. And that program can then also provide free treatment for 20% of the population who can't. And that was really the basis for the Uzbekistan program. From the beginning, we started the program in December of 2019. And as of today, we've screened 50,000 people for hepatitis B and C. All of this is provided free of charge. Viral load tests for hepatitis C patients. We are doing EPRI to determine the stage of fibrosis. All medical services, nurses, doctors, all of that is provided free of charge. And then the treatment is provided for hepatitis B patients at less than $10 per month to the patients. And for hepatitis C, it's less than $200 for a cure, actually. Now, remember, that includes paying for all the diagnostics and lab tests. The program has been incredibly successful. It enables the government to actually really get engaged, because they were interested in viral hepatitis elimination, but they weren't committed. In fact, in 2021, they have already committed to purchase 400,000 rapid tests for hepatitis B and C. So this program will continue and expand into a national program. And in fact, we're working with them now to expand it to all regions in Uzbekistan. I'm going to pause there and stop there, and of course, be happy to talk about and answer any questions. But I have to say that we did have to have a 6-month shutdown for COVID-19, but the program actually restarted in August, and we're currently underway, and patients are still coming in today. Thank you.
Thank you, Homi. I think innovative ways to get these interventions to people at the country level, at the subnational level, are critically important. We don't have a global fund that is supporting the work that we do in viral hepatitis. So very, very exciting to see this, this innovative catalytic funding model actually working on the ground. Next up, we have Nasaman Wanlab Pakorn from Bangkok. She works at the Faculty of Medicine at Chulalongkorn University. And Nasaman is going to tell us about some very exciting work that's underway in Thailand around hepatitis elimination. Nasaman?
Thank you. Thank you, Michael, for your kind introduction. And thank you, the organizing committee, for giving me the opportunity to be here and share our experiences in Thailand. So talking about health equity, Thailand has established the National Health Security Offices, or NHSO, in 2002. The NHSO was established to provide universal health coverage to all Thai individuals at no cost. Currently, the free screening anti-HCV has been implemented in high-risk individuals at no cost. And high-risk individuals mean people who inject drugs and people living with HIV. So once the screening test is positive, confirmatory tests and lab assessment for treatment initiation are performed, also at no cost. However, the direct acting antiviral agents are given under specified conditions. For example, HCV genotypes must be provided, or individuals must have significant fibrosis before they can be eligible for treatment. In the next few years, the Thai government plans to expand screening tests nationwide in order to cover all people living in Thailand under the health universal coverage. And also the criteria for treatment initiation will be adapted in order to be more accessible in rural settings. Our research group is conducting a test to treat model program in order to inform the government on the budget needed to do the nationwide screening and treatment. So we select Phetchabun province as the model. So Thailand has about 76 provinces, but we choose one province, which is Phetchabun, because in this province, the adult HCV prevalence is as high as 7 to 15% compared to other provinces in Thailand. And actually, the average HCV prevalence in Thailand is about 2 to 3% in adults. So with the support from the National Research Council and also the support from NHSO, we are now expanding to screen all adults living in Phetchabun for anti-HCV and HBs antigen using the rapid point-of-care test at the primary care settings. Once the seropositive individuals are identified, HCV RNA PCR will be performed with no cost at district hospitals. And when treatment is indicated, the NHSO will provide direct-acting antiviral agents to patients at no cost. We hope that the results of the Phetchabun model will be useful as a guidance for other provinces and also finally form a policy for the nationwide test and treat program, which we hope that we will achieve the elimination targets in 2030. Thank you.
Well, congratulations, Nasaman, for getting that program up and running. I think something like universal screening, certainly in populations where there is a minimum threshold prevalence, is the only way we're going to get to elimination.
Yes.
And here in the United States, just this year, our CDC changed their recommendation. John had mentioned in the intro the baby boomer screening recommendation from 8 years ago, but we know that we're missing a lot of people. And so very exciting to see what's happening in Thailand, and we look forward to following the progress there.
Thank you.
Next up is Maria Buti, and Maria is a globally recognized researcher for her work in liver disease, specifically hepatitis B and hepatitis C, but other liver disease as well. She is currently professor of medicine and chief of internal medicine and hepatology at the Hospital General Universitari Vall d'Hebron in Barcelona. Maria, give us an idea of what you're working on these days.
Thank you, Michael, for these kind words. And thank you also for the invitation. I am working in Spain, and Spain it's a country that is one of the first that will reach hepatitis C elimination by 2030. And I think these good news are possible because we have a national plan. This national plan started 6 years ago. And at that time, in the plan, the prices of the drugs were negotiated a low price. We have also an universal health systems that cover everybody. That means that we have access to screening, diagnosis, and treatment free of charge. All the medication is provided free of charge. And I think we have almost eliminated hepatitis C in general population, but we still have some problems in vulnerable populations, particularly in people who inject drugs and also in migrants, people that usually don't have access to the hospitals. In Spain, the treatment is given at the hospital level. So I think now in the next years, we have to work at the community. And in addition to provide screening and diagnosis and treatment in these populations, we have also to work in harm reduction programs. Because if you look at the number of needles and syringes provided, it's by far lower than those that WHO recommends. Spain, as another 7 European countries, high-income countries, will be among these 11 countries that HOMI has predicted will eliminate hepatitis C by 2030. And if you look at these 8 European countries, all share the same characteristics. A public health system and access to diagnosis and treatment free. But Europe is very heterogeneous, and we have still some countries, countries like Russia. If you look at WHO region, Europe, Russia is one of the biggest countries, and in this country, they still know the number of cases of people living with hepatitis C. They still have limitations to PCR tests for diagnosis. So I think we have to work in equity. This is really important if you like to achieve a global elimination.
Thank you so much, Maria. What I did not mention in her intro is that in addition to her highly regarded research, Maria has been very involved in the public health response in Spain, and Spain has really been a global leader in responding to the hepatitis C epidemic, and was one of the first countries to really, one of the first high-income countries to really negotiate the prices of the DAA to a level that was amenable to getting the drugs out to everyone who needed them. So thank you for that, Maria.
Thanks.
So it wouldn't be a session around equity if we didn't get a question from Manal El Said about children and hepatitis. So I'm going to ask John, what is the coalition planning to do to include elimination of viral hepatitis in children?
Well, the first order of business is, hepatitis B prevention in children. They're at the highest risk of transmission, particularly from mother to child. Once infected, 90% remain infected. 1 in 4 will develop liver cancer or cirrhosis in later life. And so really affording that level of protection to every infant is really job one, I believe, for hepatitis elimination. It's really the cornerstone of hepatitis B elimination, and you see profound benefits when you have a highly effective program in countries like Thailand and China and a number of others. For hepatitis C, I think we have a lot of more work to do about what's the right screening approaches for pregnant women. Obviously, it makes the most sense to screen women early before they become pregnant, get them cured so that it doesn't really become an issue for their pregnancy. So I think it only reinforces the benefits of early testing for populations at highest risk. I think the all-adult testing recommendations that have been put in place now for the United States really provides a foundation to for obstetricians to provide testing for their patients much more universally than has been the case before. And I think we have some operational research to do as far as the natural history of hepatitis C among persons who were infected in early life, and to so that we fully understand the consequences of that. But needless to say, it's been very positive that we've had progressively younger ages that are recommended to receive these hepatitis C treatments. So, hopefully we can really put this together as a maternal and child health package where you're protecting the health of the mother, but if the mother is infected, you really have the right screening in place for the infant so that the therapeutic decisions can be made appropriate for that individual. And so we're seeking to put all of that in our evidence base at the moment, which focuses very heavily on birth dose implementation, and then to add this additional information around hepatitis C among children so that we can begin to share more and more of those lessons learned for programs directed to those populations of children at risk for hepatitis C and B.
Great, thank you, John. And I'll just say when the history of the elimination of viral hepatitis is written, the chapter on elimination of viral hepatitis in children will be dedicated to Manal El Said. The next question I would like to ask Nasaman. John mentioned birth dose for hepatitis B. Hepatitis B is hyper-endemic in Thailand. What can you tell us about the response to hepatitis B in Thailand and getting that timely birth dose?
Hi. Okay. So since in Thailand, more than 99% of births occurs in hospital, so we have an opportunity to give a very timely HB birth dose in probably more than 99% of infants. And HBIG is available only in some settings. And we also achieved a very high infant vaccine coverage for at least 3 or 4 doses of HBV before 6 months of age. And last year, we also initiated TDF prophylaxis in pregnant women under the universal health coverage as well. So we are expanding the coverage of TDF in pregnant women. So we hope to eliminate HBV in children very soon.
Oh, that's great. Thank you, Nasaman. And Maria, unfortunately, has to leave us a little bit early. So I wanted to ask you, Maria, what can you tell us about what's happening in Spain around hepatitis B and the response there?
I have the feeling that in the majority of Western European countries, hepatitis B, because the prevalence is lower than hepatitis C, elimination is behind hepatitis C. And probably we have some pockets, as Jeff Lazarus have shown, in Western European countries that still the prevalence of hepatitis B is high, like migrants. And I think we have to educate and increase awareness on these special populations and try to combine hepatitis B and hepatitis C elimination together. We are doing a big effort for hepatitis C. Hepatitis B and C viruses share the same mechanism of transmission. Why not to work with both diseases together? So I think in the future we have to work more on combination of these eliminations programs, not make hepatitis C such one program and hepatitis B another program, depending on the prevalence of these infections in each country.
Wonderful. Thank you, Maria. I think that is one of the issues that a lot of governments, a lot of states, a lot of subnational regions are dealing with. You know, hepatitis B and hepatitis C. The epidemiology is different. The affected populations certainly overlap, but are different. And you know, it's much easier to come up with a plan to eliminate hepatitis C, for example, than it is for a viral hepatitis elimination plan. But really using the resources that are out there, and certainly on the prevention side, it does make sense to make a broader viral hepatitis elimination plan, and to really to stretch and meet those goals. And speaking of those goals, Homie, you've done some really exciting work looking at the progress that each country has made and their likely date of achieving the viral hepatitis elimination goals. And a handful of states, nation states, Spain among them, are on target to meet the 2030 goals. What can you tell us about the progress of the states that really, you know, aren't quite there, and what advice would you have for these countries to kind of catalyze, as it were, the movement toward those goals?
Well, thank you, Marco, for the opportunity to comment on this. This is a topic that's on our mind every single day. So we want to definitely recognize the activities and the movements in countries like Spain, like Egypt, Georgia, Iceland, that have done just a fantastic job. France, UK, and we'd like them to actually continue, because these are the gold standards for the other programs. But as we know, the fact is that the majority of the global infections for hepatitis B and C are in low and middle income countries. And so we're seeing countries like Pakistan, who's taking an active role now in elimination. But the problem with elimination always comes back to funding, right? So who's going to actually pay for it? And what we're seeing in a lot of low and middle income countries is the fact that they're still waiting for donors to step in. I am here to tell you, they're not coming in, right? So there may be global fund may come and play a small role in the co-infected population, but we're not going to get the same level of activity and funding that HIV is receiving. So we need to take governments to take ownership of these programs and move forward with them. That is key. It's the political will to actually do something about that. So we see a lot of really positive activities, and we want to recognize it in Mongolia. I mean, the work that's going on in Australia. I mean, these are, and of course the discussion regarding Thailand. This is fantastic, but we need to do a lot more, and the governments need to take ownership for these programs and actually start doing it. Now, there's one of the things that's nice about viral hepatitis is not just our group. There are many groups that have done these analyses. MSF just recently published. Hepatitis C elimination is cost saving. Governments will actually save money over the next 10 years if they implement these programs. Hepatitis B treatment and programs are highly cost effective. Again, we're not talking about countries sinking in a lot of money and not seeing any return. These are incredibly effective therapies. They work. We have all the tools we need. what we need is the political will for the countries to actually take on these programs.
Thank you so much, homie. I think that's part of the beauty of your model, in that it really takes just a minimal amount of startup funding to get that intervention in place, and it pays for itself. And we're very excited to see how things play out in Uzbekistan. We do have a comment here from Marinela Debu in Romania, and in response to what Maria had said, in Romania they're starting a program around hepatitis B with some EU funding, which is great, and the European Union has been very good in getting some of the funds out to do some of this work. But again, as Homie said, most of the disease burden globally are in low and middle income countries, and how do we get to the people who are most at risk and most underserved in those countries? We've got a few minutes left, and I wanted to see if there were any last words that will go around the room here. John, did you want to give a parting shot? I know we've got the close here after this session, but just generally addressing equity and those people who are either at risk or living with hepatitis B or hepatitis C and are just not getting access. Maria talked about hospitals in Spain, and people who inject drugs or use drugs, for example, have oftentimes a very negative experience with traditional healthcare. And so how do we get those folks who need it but are not really getting it or distrustful of the healthcare system?
Well, health equity is the goal, and I feel very, very strongly that we need to eliminate these disparities in health, and that is the ultimate objective for elimination. But you really have to pick your strategy, and that's what I was trying to get across in my prepared remarks, because at the end of the day, you want to do it in a way where people own the problem and they don't marginalize the populations at greatest risk that you're really trying to reach. And so you really want to make it I think really a problem that everybody feels like they have a stake in, rather than that's not my problem, it's someone else's problem in the country. So really create that countrywide perspective. There's an old saying in public health that the art of public health is to merge the needs of the poor with the fears of the rich. And to really see what's in it for me, throughout society by reducing this transmission or more disease burden from these populations. So I think we always have to continue to strive to, have health equity of our goal, but realize we need to do it in a way that really truly helps them rather than further marginalizes them.
Well, I think that is a perfect way to wrap up this session, John. Thank you very much. I would like to thank our panelists, Homi Razavi, Nasiman Walapakorn, Maria Booty, who did have to leave a little bit early, and of course, John Ward. That was a very stimulating discussion, and I look forward to John and Huma closing out this really great conclave. Thank you, everyone.
Thank you. I guess we can take it on. Thank you very much. It was a great 2 days. We would have had full 2 days. We've been together in person, but we had 2 half days essentially in replacement virtually, and hope everyone got as much out of the program as I did. We had a nice overview of from WHO and from the Global Burden of Disease study describing the large burden of disease that continues to be the case for hepatitis, but also recognizing some improvements in the burden of disease globally for hepatitis B, as well as for countries that were reporting their progress in their hepatitis elimination goals. We had a very thorough discussion about the impact of the COVID-19 pandemic on our efforts to eliminate hepatitis, both how it's interfered with service delivery for vaccination care and treatment, but also some opportunities to improve access to care and testing and treatment going forward because of some of the innovations that have been put in place to continue service delivery during the COVID-19 pandemic, and also improvements in the diagnostic capacity, the command and control structure within health systems, and infectious disease training provide additional opportunities. And we really need to be at the table as people begin to think about how to develop more resilient health systems in the future to prepare for the next pandemic. I had a very nice overview of transmission of hepatitis B and hepatitis C among children, the consequences of those infections among young persons, and what are some of the strategies of improving prevention, care, and treatment. And then I think we've had a great presentations from a variety of countries looking at various programs for hepatitis B and hepatitis C, the strategies put in place, and the various partners that's making that implementation possible. I think that's really one of the main goals here is get those lessons learned shared so people can really take those back, see if they apply to their programs for improvement or even really motivates them to get started. And I know everyone that's been part of this conference is more than happy to help, as I am at the Coalition for Global Hepatitis Elimination. I'll turn it over to Huma for her thoughts about the program.
So thank you, John. Dear participants, it was a pleasure having you at this World Hepatitis Elimination Meeting 2020. Despite being in the different time zones, we had good participation and we had very rich content and rich discussions. Hope that the next meeting is not virtual and we can see all of you again in person. There has been great work all over the globe on hepatitis. And now we see that the governments are also showing their commitment and are investing in its elimination, which is a very, very good move. We have a decade only to eliminate the disease and achieve the WHO targets by 2030. So there's a need to have more coordinated efforts and learn from those countries that have been successful in achieving the targets. So thank you, and over to John.
The next slide, please. I want to thank our sponsors again for making this this meeting possible, and particularly Gilead Sciences. Next slide, please. And also thank again our variety of endorsers of organizations who share our commitment to viral hepatitis elimination. Next slide. And again, please use the feedback option so we hear your opinions about what you liked and about the conference, what you thought could be improved, and so that will improve our planning for IVHEM 2021.
So next slide. There is about Ricky and her team, because as we were informed that once we send our photographs, the team will stitch it together and kind of put it as the group photo. So you can see how good these tailors are. So they're really good teams. Thank you very much. And next slide, please. So after the closing, there's a live poster viewing. Please join this and see the remarkable work that people are doing. So thank you very much, and please join the poster viewing. Thank you. Bye-bye.
Bye-bye. Thank you.
Thank you, John.